can see here that these are the areas of the world where these tropical infections are most common. The reason behind is the warmer climate, the higher amount of rainfall, lot of grass, greenery. These all things lead to proliferation of insects, mosquitoes, and ticks. And the bites and the infection caused by these organisms or the insects, they will lead to infections which are peculiar to this area, and that is why it is called as tropical fever. So tropical diseases are often defined as the diseases that are prevalent in or unique to tropical and subtropical regions of the world. And it is increasing day by day because of increased interaction between humans being closer to animals, the forest area being reduced, and people going more for work, for vacations and all. So all these things are causing zoonotic diseases. Will lead to some certain types of infections, which includes typhoid, amoebiasis, and viral hepatitis. To know the impact of tropical fever in ice, INDICAP study was performed in 2016. So they recruited patients from 20 ICUs in India, and almost 231 patients had tropical infections, and a very high percentage of these patients, 21.7% of these patients, died because of these infections. In another study, Parekh, for of the patients admitted to ICU of a public hospital in Mumbai were for tropical infections, whereas Yolekar, he mentioned that during monsoon months the epidemiology may increase up to 80% of the beds, which is quite phenomenal. WHO also recognized this as a very important part of their program, and they say that it is partly a neglected topic because these infections are common in tropical countries, and that is why it lacks global and national public health attention. We see that these infections are very rare in European country, Australia, Japan, China, US, and that is why not a lot of research is happening in these areas, and not lot of vaccines are, and 1.2 billion people are requiring treatment, and 2 lakh deaths can be prevented every year by simple preventive measures and simple treatment of infections. So when we talk about how to approach and how to treat these tropical infections, we talk about syndromic approach. The reason behind syndromic approach is that the clinical picture of all these infections are overlapping. They will present to you with history of fever. It may be associated with some sort of rash, hypotension, thrombocytopenia, and mild derangement of the liver functions. SGOT, SGPT will be slightly increased. Then management of all these patients with tropical infections must begin immediately. And most of the time, empirical therapy needs to be initiated at the outset. Although there are no uniform guidelines, but in 2014, a guideline was published by ISCCM, which has been a cornerstone for managing all these patients throughout the world. So the main idea coming from these guidelines were that you need to hit wide, hit early, cover all the types of tropical infections at the same time, and go for diagnosis. Once you get the diagnosis, then you de-escalate your treatment. And that is what is the basic approach in initial therapy. So they further say that spectrum of organ involvement is divided into presence of fever with thrombocytopenia, liver involvement, renal involvement, neurological involvement, rash, pulmonary syndrome, or a GI syndrome. Another study, this was performed by Dr. Singhi et al. From 34 ICUs. They found that amongst all patients, dengue had 23% incidence, strep typhus 18%, encephalitis 9.6%, malaria 9%, hepatitis, typhoid, and leptospira 1%. So coming to the important part of management, first is history. So this is very important. You must take a history whether the patient has gone outside or not, because geographical variations are there, endemicity of diseases are there. There are places where some infections are more prevalent. There are places where some other infections are more prevalent. What activities the patient did in last few days, like swimming, wading through monsoon floods, working in fields, food, whether outside food was consumed or not, contact with animals was there or not, and history of bite. This is very, very important. Then you must also ask about vaccine history as well as the prophylaxis history, especially from the patients who are traveling from outside. Then you must know the incubation period of common tropical infections. For malaria, dengue, rickettsial, typhus fevers, leptospira, and typhoid fever, the incubation period is almost less than 2 weeks. Then it for malaria and typhoid fever, along with hepatitis A, E, liver abscess, and leptospira, the incubation period may vary from 2 to 6 weeks. And if the incubation period is more than 6 weeks, then the diagnosis can be malaria, tuberculosis, or visceral leishmaniasis. And I can say that during these monsoon periods, I have seen all the infections, including the leishmaniasis, in my ICU also. Okay, so I have seen everything. And this is common for all other ICUs in North India as well. So the ISCCM article, which is the guidelines for ease of diagnosis, tropical infections are divided into 5 major syndromes. First is undifferentiated fever. That means fever with no other organ dysfunction. Then fever with rash and thrombocytopenia, fever with pulmonary disease, that is ARDS, fever with encephalopathy, that is neurological problem, and then fever with MODS or having liver and renal dysfunction or shock. So if a patient who presents to you with undifferentiated fever, the differential diagnosis mainly will be malaria, strep typhus, leptospira, typhoid, dengue, and other common viral illnesses. If the patient presents to you with rash, then the two major diagnoses will be dengue and rickettsial infection during these seasons. And if the patient is also having some neurological problem, then you must suspect meningococcal infection. And other possible differential diagnosis will be malaria, leptospira, measles, rubella, and other viral exanthems. If the patient is predominantly presenting to you with pulmonary symptoms, which is probably the most common type of presentation who comes to you in ICU, then the differential diagnoses are strep typhus, falciparum malaria, influenza infection, that is a new thing, H1N1, leptospira, hantavirus, melioidosis, severe CAPS, strep pneumonia, and do not forget diffuse alveolar hemorrhage due to collagen vascular disease. Sometimes we think that only because we are seeing a monsoon season, we only focus about the tropical infections or the bacterial infections, but the patient may have some other disease like ANCA-associated diffuse alveolar hemorrhages, which are diagnosed during these seasons. For you have to see about herpes simplex, Japanese bee, and other virals. Meningitis includes strep pneumonia, Neisseria, Haemophilus influenzae, enterovirus, and then strep typhus, malaria, and typhoid. These are also infections which can cause severe encephalopathies leading to comatose situation. Then patients who come to you with MODS, first we have to always rule out bacterial sepsis, but tropical infections can cause all these types of MODS, and we have seen all these infections like leptospira, strep typhus, dengue, malaria, all these causing MODS. And viruses like hepatitis A, hantavirus, they all also can cause MODS. A very common mechanism which predisposes these patients into MODS is hemophagocytosis and macrophage activation syndrome. Many of these viruses cause these macrophage activation syndrome, or we now call it as HLH. So this HLH causes thrombocytopenia, leukopenia, and then causes multi-organ failure, and they are very difficult to treat. And you need to give a lot of immunosuppression to treat these complications. So a patient who will present to you, it will take time to diagnose which type of tropical fever we are dealing with. So when you do not know what is the positive organism, but you have to treat because the patient is sick, then an algorithmic approach is the answer. So as we do for any other type of infection or complication or any other type of disease, first we have to assess and stabilize ABC, which is a work of intensivist or work of anesthetist. Always look for red flag features like presence of tachycardia, tachypnea, and hypotension. If these things are there, then the patient needs an urgent ICU admission. You look for focus of infection. You have to look for pneumonia, pyelonephritis, biliary source, cellulitis. You have to send appropriate investigations, including the cultures, and empirical treatment has to be started. We'll be discussing next slide. Then you have to assess the clinical syndrome, consider the history, examination, risk factors, geography, season, and then you go accordingly. If the patient is having encephalopathy, then there is a separate algorithm for that. But for all the other things, we have a single algorithm. This is the step one. ICU admission and look for the source and then divide it into fever with what type of syndromes which we are dealing with. Then the investigation which has to be performed, essential to be performed in all, is obviously blood culture, because the patient is having infection. You do not know whether it is tropical or a bacterial one. You have to send routine investigation, including a CBC, platelets, electrolytes, CRP, creatinine, LFT, urine analysis, and chest X-ray. You can add ECG and ABG to it also. And then you have to perform rapid diagnostic test. Tropical, that includes malaria, that includes dengue and typhoid. For leptospirosis as well as scrub typhus. These are the guidelines published in 2014, and as the incidence of other infections like scrub typhus and leptospirosis increase, now we have started to send all these infections at the first go only. And then we come to the test, reports of the test and the treatment. So if the rapid test, which will give you an answer within few hours, suggests any diagnosis, like if the malaria is there, then you have to start artesunate. If dengue is there, then you have to give fluids and supportive care. And if typhoid is there, then you have to give injection ceftriaxone at 100 milligram per kg per day. But if there is no rapid tests which are positive, then you have to start a broad spectrum treatment, which will include ceftriaxone, doxycycline, and plus minus of azithromycin, depending on the seriousness of the case. You will go for further workup, which includes advanced tests like ELISA test, serology for scrub typhus, leptospira, Vidal test, and you will also perform USG abdomen, and if required, then you may go for a bone marrow examination and culture. So this is the algorithmic approach for the critical tropical infection. So first, again, I'll summarize it. First, you have to look for ABC. If there are red flag features, admit the patient into ICU. Try to identify the focus of the infection, and also look whether what is the syndrome of the patient. Depending on that, you have to investigate, and you have to send your rapid diagnostic test. If it comes out to be positive, then treat that particular infection. If it comes out to be negative, then you have to start empirical treatment in the form of ceftriaxone, doxycycline, and plus minus of azithromycin plus other supportive care. Right? If the patient is coming to you with encephalopathy, the patient is confused, agitated, irritable, or the patient is comatose, or is patient having seizures, then you have to think about some other major differential diagnosis as well. That is why the treatment approach for encephalopathy and the algorithm is a little different. Basic remains the same. You have to first support airway, breathing, and circulation. Check for blood glucose. If it is normal, then okay. If it is high, then you have to infuse dextrose and check whether the hypoglycemia is the reason for your altered sensorium. If it is high, then you start insulin. Check for the hydration status. If it is normal, then it's okay. More likely that the patient will be dehydrated, start giving normal saline. If the patient is having any seizure activity, then you have to give anti-epileptics. Take group history, good examination. Check for any signs of raised ICP. If they are there, then you have to give mannitol or the 3% saline. And you then go for, if there is no raised ICP, then you can go for lumbar puncture and you have to check for CSF test. And apart from routine tests, you have to also send ZNC, India Inc. and viral PCR for herpes and Japanese encephalitis. Sometimes you also send it for tuberculosis, and you have to again perform rapid tests for malaria. And if it is suggestive, then you have to start artesunate. If they are not suggestive, then presumptive therapy in encephalopathy is ceftriaxone plus acyclovir to cover for the herpes infection. Meanwhile, you also can look for Vidal tests, scrub typhus, leptospirosis, dengue, and other tests. And if they are give specific type of complication that we must remember, and the reason behind, we will come to that in next few slides. Just one more thing, if the patient is having raised ICP, then you have to also go for neuroimaging to check for whether what is happening inside the brain, whether there is any bleeding is there or not. So you have to check it out. Then if the patient is coming with fever with thrombocytopenia, but we do not know what is the diagnosis behind it, the treatment for that is antipyretics, avoid anticoagulation aspirins, watch for bleeding, dyspnea and shock. Platelet transfusion if the platelet counts is less than 20,000 or if there is any clinical bleeding, and there is no role of steroids for fever with thrombocytopenia, that we must remember. If the patient is coming with jaundice, then you have to give injections of ceftriaxone and tablet doxycycline, because the scrub typhus and leptospira, they are the common infections which lead to jaundice. So to cover for them, doxycycline is required, and you have to watch for any complication. FFP or cryoprecipitate is required if there is any bleeding, and specific therapy once the diagnosis is established. And if the patient is coming to you with fever with renal failure, again treatment is ceftriaxone, doxycycline, and IV fluid as per the clinical hydration status. CVP, it may be used, it may not be used. It has a lot of drawbacks, which will be discussed in some other class. Then you have to also watch for encephalopathy, bleeding, seizures, ARDS. Again, you have to see for other organisms. RRT if required, and specific therapy once the diagnosis is established. This we have already discussed, covering the fever with encephalopathy, antipyretics, ceftriaxone, acyclovir, IV fluids, mannitol, anti-epileptics is required, and specific therapy once the diagnosis is established. Fever with ARDS, again control of fever, IV fluids, oxygen, ceftriaxone, azithromycin here is preferred, and oseltamivir, because influenza infections can also cause fever with respiratory distress, and you have to give specific therapy once diagnosis is established. So broadly speaking, ceftriaxone, doxycycline, azithromycin, and oseltamivir, acyclovir, these are the 5 medicines which will be used apart from IV fluids, control of fever, and watching for any other organ.